Okay. Well, hello, everybody. It's 4 o'clock. I think we can go ahead and get started. I'm Phyllis Leverich. I'm the Western Slope Outreach Coordinator for the Parkinson Association of the Rockies. I'd like to make a few announcements before I start. First of all, I wanted to let everyone know that our Care Partner Summit is happening on May 10th at the Aurora Hyatt, and we have a couple of really good speakers lined up. We have Jane Barton, who's going to talk about compassion fatigue when it hurts to care, and Kay Adams, power of boundaries and empathy in preventing burnout. Our chats with the Parkinson's Pro begin in April, and there are a lot of them all over Colorado and Wyoming. So I'd encourage you to visit our website for details on the chats. And then our Vitality Walks start. The first one is on May 17th in Pueblo. And then we have one in Denver on June 1st, and there's three others besides that. So be on the lookout for more information coming your way about those. I'd like to ask everyone if you could please mute yourselves right now. If you could click the little microphone next to your name so that it's red and has a slash next to it. And if you have trouble doing that, don't worry. I can come along and mute you.
My Dennis Royer doesn't have anything but his name.
Okay.
I would gladly
I
do
think
that.
I've got you. I can mute you right now.
Oh, thank you.
There we go. So yeah, let me just take a moment to make sure everybody's muted. And if you have a question, you can either type it in the chat and one of us can ask the doctor, or if you want to, there's a little react button at the bottom of your screen, a little heart. And if you click on that heart, there's a little hand, and you can raise your hand, and then I can unmute you so you can ask the doctor a question. So I'd now like to introduce Dr. Luisa Solis-Cohen. Dr. Solis-Cohen is a board certified neurologist and movement disorder specialist practicing at Neurology of the Rockies. She earned her medical degree from University of Buffalo School of Medicine, and completed her neurology residency and movement disorder fellowship at Beth Israel Deaconess Medical Center, a Harvard training program. Dr. Solis-Cohen has been dedicated to the care of individuals with Parkinson's disease and other movement disorders since establishing a movement disorder clinic in Colorado in 2017. Her clinical interests include Parkinson's disease, essential tremor, dystonia, and advanced therapeutics such as deep brain stimulation and botulinum toxin injections. She is also actively involved in community outreach, clinical research related to Parkinson's disease, DBS therapy, and palliative care, as well as teaching neurology residents about movement disorders. So welcome, Dr. Solis-Cohen, and thank you so much for being here today.
Thank you, Phyllis. I appreciate it. I think everybody's ready and everybody can hear me, but feel free to disagree. I'm not going to keep track of the hands and the questions, but I am very open to being interrupted. I'd rather answer a question as it comes up than circle back at the end. So feel free to make this yours and interrupt away. I can talk forever without being interrupted, so I encourage interruptions. So I'm Luisa Solis-Cohen. I'm a neurologist and I'm a movement disorder subspecialist. So what that means is that I've gone through all neurology training and then dedicated additional time to the subspecialty of movement disorders. And Parkinson's disease is a very prevalent movement disorder, but it's actually not number one. Number one most common movement disorder is actually essential tremor. But it just so happens that the population is aging, and as we get older, the risk of Parkinson's disease goes up, and Parkinson's can cause a lot of symptoms that require frequent ongoing medical care, particularly with a movement disorder specialist. So that's what a movement disorder doc does. We kind of feel like a primary care for a person with Parkinson's disease. That's what I like to say. So here's what our objectives are. We're sort of going to start and develop this framework together about what Parkinson's disease is. What are the risk factors? How common is this? How does one come up with the diagnosis? What is that based on? You may have heard of these terms Parkinsonism versus Parkinson's disease. So we'll give some education on that. Heard of motor symptoms about how the body moves versus non-motor symptoms, which are other body symptoms or systems that are impacted by this condition. We'll take a break, and then when we come back, we'll try to get through everything on the bottom of this list. We're going to look at the most important treatment, which is exercise. We'll talk about what medications do, what the concept of a motor fluctuation is, some more advanced treatment options, and I'll leave you with some resources. Just reorienting my screen here. Give me a second. All right. So what is Parkinson's disease? People can define this in many different ways. There's many different descriptive terms to come up with what this condition is. We call Parkinson's a neurologic because it affects the brain and the nervous system. And then we'll use this term called neurodegenerative, which means that it's neurologic and things degenerate or get worse over time. So we know that this is a progressive or degenerative condition, and it involves several different processes, but the most common thing that you'll hear us talk about is the loss of dopamine producing brain cells. So a brain cell is a neuron, and the neurons that are responsible for dopamine are not as common as they should be. They're less numerous and they're making less dopamine. You'll also hear of this term called Lewy bodies. And Lewy bodies are an accumulation of this abnormal folded protein called alpha-synuclein. Now, we all have alpha-synuclein. It's a protein that everybody has in their body. But for some reason, it's misfolding. And when it's misfolded, it is no longer identified as something that needs to be recycled. And basically, the neurons will kind of trash it. They'll recycle it and get rid of it. But when it's misfolded, that doesn't happen. And so it accumulates. And it accumulates in these little collections called Lewy bodies. And those happen to be found in this area of the brain called the substantia nigra. And so we see those Lewy body accumulations in that area of the brain in folks with Parkinson's. And you may say, well, I've heard of this condition called Lewy body disease. And there is another condition called dementia with Lewy bodies that also has Lewy body accumulation. It is not specific to Parkinson's. You'll hear Parkinson's be termed as a movement disorder. And a lot of people focus on these visible signs, these visible symptoms like tremor, slowness, stiffness, walking and balance difficulties. And when a person talks about Parkinson's, they think of this typical scenario where a person has one hand shaking and is stooped over. But as we know, if you've been in a room with a number of people who have Parkinson's, everybody has a symptom constellation that looks a little bit different one from the other. Okay, so not everybody's symptoms are the same. All right, so the dopamine deficit here. So individuals who have Parkinson's, if you take a look at their brain, a deep part of the brain, this area that's highlighted here in color, I don't know if you can see my cursor. See laser pointer. Oh, there we go. So you can probably see that now. Let me know if you can't. But this part in color is called the midbrain. And this dark area here is called the substantia nigra. And that is a normal part of anatomy. When anatomists first looked at this part of the brain, they called it the black stuff, which is substantia nigra in Latin. And so this part of the brain is darker. And as the brain cells are less prominent, there's less of them as they become injured and die, there is less of that pigmentation. And so there's a diminished amount of this substantia nigra in Parkinson's. The next picture we'll show you is what happens on a more microscopic level. So what we're seeing here is we're actually seeing a cartoon, and one neuron is actually connecting with another. So these blue aspects over here and here, those are brain cells or neurons. And the first one over here is extending an arm projection to the other brain cell here. And it is able to talk to it by releasing a chemical, and that chemical is dopamine. You'll hear us say neurotransmitter, or a neurological transmission of signal using a chemical from one brain cell to the next. Now, in a normal neuron that releases dopamine, if there is a certain amount that is correct for this brain cell to talk to the next, there'll be normal fluid movement. However, if there's a dysfunction of that, what you'll see is you'll see a loss of fluidity of movement, breakdown of movement, slowness, and so forth. Okay, here. The next thing that we see is this is actually under a microscope. And so this is a real-time slide of what happens in the brain. And what we see is we see a dopaminergic neuron, or a dopamine-producing neuron. It has one arm projecting outward to another cell that we can't kind of see on that cut of the slide. There's another arm projection that should be there. And we see this brown blob in the middle. And what do you think that is? Well, that's what we talked about earlier. It's a Lewy body. And those Lewy bodies, they're full of this thing called alpha-synuclein, that alpha-synuclein that's misfolded and that can't be recycled from the cell as it should be. Anybody have questions on this before I move forward? And I'm sorry, I'm a little distracted because there's things floating on top of my PowerPoint that I can't make go away. Any questions so far?
Apologies for joining late. May I ask a question?
Sure.
So the alpha-synuclein, I'm in a situation where I was diagnosed based on a SIN1 test. Are you familiar with the SIN1?
Yeah.
So they put me into a clinical trial, and the clinical trial, the first thing they did was run a DAT scan. And the DAT scan came back normal. I have no dopamine deficiency, and everything looks normal. So I was withdrawn from the clinical trial, and I'm going to see my neurologist tomorrow. But because I had this alpha-synuclein present, or abnormality in that test, like, I guess I'm still a candidate for Parkinson's, am I not? Because of the presence of the alpha-synuclein?
So you're asking a very specific question that's beyond the level of this talk. I would recommend that be addressed one-on-one.
Thank you.
I'm happy to answer that offline, but I don't think it's appropriate for me to kind of discuss your case with everybody here. That's a much higher level discussion.
Thank you.
Yep.
Apologies.
No worries. I just don't want to do you a disservice. That's what I'm going to say. Anybody else? All right, we'll keep going here. So the next part of our talk is to talk about how common this condition is. And like I said before, Parkinson's is the second most common neurodegenerative disorder. Actually, I was talking about movement disorders before. So it's the second most common movement disorder, and it's the second most common neurodegenerative disorder, second to Alzheimer's, actually. Now, there's 1 million individuals in the US living with Parkinson's. 90,000 in the US are diagnosed each year, and over 10 million people living with Parkinson's worldwide probably even underestimates the actual numbers. This was from a few years ago, study. The incidence of Parkinson's in North America is where those numbers came from. This is a 2022 study. And the take home from that look was that the primary risk factor for Parkinson's is age. and the incidence increases as folks are older than 65 years. Of course, Parkinson's onset can happen pretty much at all age brackets. We know of folks who have very young onset Parkinson's, even in their 20s, and even as early as teen years. The incidence is higher in men than in women at all ages. And this number of 90,000 is 1.5 times higher than previously reported just years prior. And so as years go on, we're going to be diagnosing and seeing much more Parkinson's as the population ages together. The Parkinson's Foundation has this map of prevalence by state, and I just included it so you can see Colorado people with PD or Parkinson's is 15,000. And some states are much higher than others, and that has to do with exposures, environmental exposures as the biggest risk factor. And we'll talk about that. So Parkinson's disease doesn't just come about from one thing. It's not just from genes. It's not just from environment. It's not just because of your age or gender. It's what we call a multifactorial hit. So it's a combination of environmental and genetic factors. And it culminates into Parkinson's. And sometimes in one person, the genetic factor will be much more heavily contributing to this condition than in other people. So some environmental factors that we know to be true, and this list is not all inclusive. There are a lot of hotly debated things as to whether they contribute or not, but this one is a general consensus among movement disorder docs that there is a risk related to certain toxins, and just two to be noted are pesticides and herbicides. Some chemicals like solvents and PCBs. Agent Orange is associated with Parkinson's, and if you've had Agent Orange exposure and Parkinson's, it's a covered benefit or a covered condition. Head trauma is associated with Parkinson's, Parkinsonism. There's not just Parkinson's associated with head trauma, and it's not just one head injury either. Genetic factors. Now, more common, a person who has Parkinson's is the only one in their family. Less common, 10 to 15% of cases, have people in their family with Parkinson's because it's more a greater genetic tendency in this family, that it's passed down from generation to generation. But an individual who comes to see me and will get their first diagnosis, let's say, they have a much greater risk of them being the only one in their family to get it. And that's called sporadic Parkinson's, okay? One person in the family, there's not this high genetic risk. The second bullet point there is the genes that are more genetically transmissible. And there are certain ethnic groups that have a higher risk of Parkinson's than others. And that's listed there as well. So how is Parkinson's diagnosed? So the interesting part of Parkinson's is that it's diagnosed in a clinic room with your neurologist or primary care doctor. It's a clinical diagnosis. It's based on certain features of movement, and it requires us to learn a lot about you and be nosy. So we'll ask questions like, when did it start and how did it evolve and what body parts are affected? But we'll also ask questions like, have you been on certain medications that can cause Parkinson mimic conditions like antipsychotics or long exposures to anti-nausea medications? We'll ask about certain medical conditions. People who have high blood pressure, high cholesterol, strokes may have a mimic condition. We'll talk about family history. We'll talk about lifestyle factors, potentially exposures related to your job or service in the military. So we do get kind of nosy. I call them my left field questions when we're talking about these things that seem like they have nothing to do with why you're here. Then on exam, we're looking for certain aspects of movement. So the cardinal feature of Parkinson's is bradykinesia. Brady meaning slow. Kinesia comes from kinesis or movement. So slow movement, that's all bradykinesia means. You have to have slow movement for the diagnosis. And we'll talk about some examples of that in a little bit here. You'll need the cardinal feature to make the diagnosis, and then one of the other things that are listed there as other signs. So rigidity is our term for stiffness, so muscle stiffness, that is typically on one side of the body, but can be everywhere. Shaking of a limb, we use the term tremor. People get kind of confused about tremor and how much tremor is needed. If I don't have tremor, do I not have Parkinson's? If my tremor is there when I like hold something versus when I'm resting, is it tremor? And Parkinson's does not always follow the medical textbooks about what it likes to do with this aspect of the condition. So this is not one that is easily generalized. But the most common thing is that when a person's at rest, they may see their hand shaking and they may see this certain pattern, like I'm doing here, where the thumb and the pointer finger are coming together, and there's this turning of the hand as a tremor pattern. Trouble with balance and falls. People may notice a slowing of walking with shuffling where feet are closer together. They're not as high when you pick up the feet to make a stride. And there may even be this pattern called freezing of gait, where it seems like a leg or both leg get stuck to the ground, and it's almost hard to get it off the ground to make the next step. So the next few slides take us through those features, and we'll talk about different examples, because when we say slowness, some people are like, I don't know what you're talking about. What do you mean by slowness? So some examples of slow movement are listed here. When we talk about facial movements being slow, we'll talk about sometimes people are blinking at a reduced rate, or they're not making as many facial expressions. So there's this term masked faces or hypomimia, slowed facial movements. When you think about, I hate to generalize like this, but when you think about how Italians talk with their hands, they're always talking big, making a lot of hand gestures. There's less of that in Parkinson's. So we call this like gesticulations are much less prominent, that people will talk with their hands or move when they're talking is like they're acting it out. When you sit in a chair for a long time, it's a natural tendency to reposition yourself, to cross your legs, to move your arms, kind of like a lot of you guys are doing here. And it happens less in Parkinson's. There is much more stillness and less repositioning or adjusting. So that's another form of slowness. Repetitive hand movements. So the old school toothbrush, we have to generate a rhythm. If it's slower, brushing your teeth is going to feel kind of weird, right? You don't really think about generating that rhythm when you brush your teeth, but it is sort of obvious when it's slow. I learned from folks who have particular jobs about slowness, for example, as a chef. Like, yes, I do enough cooking to know what whisking is, but I don't do a whole lot. So when you whip a meringue, apparently, if you're not able to generate a certain speed by hand, you'll not make those peaks, those lofty peaks. And so somebody's complaint to me over time was, well, I can't whip my meringues anymore. I don't know what this means, but I think it's slowness. And so there's a lot of other very unique aspects of how a person can demonstrate slowness, either related to their profession or to their hobbies. Buttoning or writing are generally things that I'll ask about because we all do them. And writing can not only be slow, but it can be small. So it'll look like penmanship has a smaller font size, right? Instead of writing in what looks like a font size 12, you're writing in like a font size 8. Or the longer you write, you'll start out big and it'll kind of get smaller as time goes on. And that is the last, well, second to last bullet point called micrographia, smaller penmanship, basically. And that is a sign of this. Walking, if it's slowed, the rate or the time with which you need to get from point A to point B will be longer. So people will say, oh, that, my loved one is now falling paces behind me when we try to go for a walk, and we've done this for years, and now all of a sudden they can't keep up. Speaking, there may be a pause before you speak, or a slowed rate when you're speaking. There's a lot of different ways slowness comes out in speaking. If you think about swallowing as a thing that you have to do a certain number of times per minute, and if all of a sudden it becomes slowed, what happens? Well, the drool that you were producing is now accumulating in your mouth. And if your mouth is open because you have slowed facial expressions, then you're going to be drooling. So that's where that whole process comes about. When people come and talk about these symptoms, they don't tell me I have bradykinesia. They say I feel weak, I feel clumsy, I feel incoordinated. And it's in this process of discussing some of these aspects that we say, oh, yeah, you're actually not weak. You're having difficulty with speed of movement. Anybody have questions about that? Okay. So tremor. So I alluded to this earlier. Tremor may not happen in every person. In fact, I even said this today when talking to somebody. Tremor is only present in about 2/3 of individuals with Parkinson's. 1/3 of folks don't get tremor. And I think that always shocks people. They think it's like a mandate of the diagnosis. But when it happens, it will classically start in one hand or in one leg. It's unusual to affect both sides of the body at the onset. It's most prominent at rest. And again, this is a person who's abiding by medical textbooks, but it's not always present at rest. So if you go to hold something and you have a little bit of tremors, it's a weird thing that my computer's doing. That doesn't like rule out Parkinson's if you have a tremor in other conditions. Tremor may or may not be bothersome to a person. If it's in their dominant hand, it's going to have a greater chance of being bothersome. If it's not just there when resting, but it's also present when you're moving around and holding something, it's probably going to be bothersome. And if it is there and it limits your ability to fall asleep, well, then it's bothersome. So not only do we talk about what kind of tremor do you have? Do you have it at rest? Do you have it when you move? Does it interfere with eating and drinking? Are you avoiding soup on a spoon? Can you fall asleep because of your tremor? All of these aspects are very important. Oh yeah, so I have some of these slides incorporated so that you guys don't forget these really important things. And this one is a myth, so this is not true. It says I don't have a tremor, so I don't have Parkinson's. And you guys have heard it from me, that is not true. Parkinson's can happen without a tremor. That's not necessary for the diagnosis. So rigidity is our word for stiffness. And stiffness is one that I think is the hardest for people to understand about their own body. So these are some interesting ways of going and trying to get that history. One is it hard for you to reach across your body? For example, to put your seatbelt on, where you kind of have to turn, right? Or put your arm into a jacket, or put your socks on. Now, as we get older, right, you're like, that's just hard because I'm old. And then it's kind of an important part of looking how at a person's exam to see, is this like just age, or is this asymmetric, where one side of the body is more stiff than the other? And does that side of the body also have slowness? Getting out of a chair or out of a car can sometimes be a helpful aspect to talk about. And an interesting thing is turning over in bed. So turning over in bed can all of a sudden be very challenging, uncomfortable, and people just feel like this is something that was never a thing they would ever have to worry about. And now all of a sudden, getting comfortable and turning and moving at night is very uncomfortable. So this is a schematic of what people typically think of when they think of Parkinson's disease. A person who's a man, who generally has shaking, who's having stooped posture, or stooping of the shoulders, and they're shuffling when they're walking. But again, you guys have heard it from me, and if you were all in the same room together, you would see that a lot of people have very different symptoms. Somebody, I think earlier, a couple months ago, used the term Parkinson's disease is kind of like everybody's a snowflake. Everybody's their own individual with this condition. And I love that. It's so true. As a person who sees Parkinson's every day, multiple cases of Parkinson's, I will tell you, they are not all the same, that everybody really has their own flavor of symptoms and own response to medication. So gait dynamics, gait is one of the most complex motor functions that we have. And there's so many contributors to gait and walking. The most common presentation is what you see here, that a person has a stooped posture, that they have a reduced arm swing, particularly on the side that's slow and stiff, that may have a tremor. There's that shuffling pattern of walking where they're kind of not picking up their feet high enough, or their stride length's not long enough. That freezing, like we said, that the foot may kind of like freeze down to the floor and not be able to pick up either one or two. And it's extremely debilitating when a person has freezing. Unwanted accelerations. Not everything in Parkinson's is slow. This is a feeling like all of a sudden they're moving too fast and their body, like their feet and their trunk, are not connected. They're on total different speeds, and that can lead to falling. Postural instability is our fancy word for a tendency to fall. And it is not expected that early in Parkinson's, there are a lot of falls. Though it can happen, it is a red flag for us to think more broadly about Parkinson's mimics or other things that are going on as to why a person would come to us as, I'm falling a lot, I must have Parkinson's. That's not the typical situation. You guys are, I'm assuming I will just keep going unless somebody interrupts me. Motor symptoms. So what we talked about thus far, those are the cardinal motor symptoms in Parkinson's. And these are kind of like the 201, if you will, motor symptoms. So like the next level of complexity. Dystonia is a word that is related to dys, meaning abnormal, tonia, tone. So abnormal tone in the body that's generated from abnormal signaling in the brain. Dystonia can happen in individuals who don't have Parkinson's and will happen in individuals who have Parkinson's. It can happen in children, it can happen in elderly, and in between. It leads to abnormal muscle position by excess tone. So if muscles have more tone and they're tighter and they're stiffer, there may be a posture associated with that. And the most common dystonias in Parkinson's follow certain patterns. One is foot inversion and toe curling, and kind of this thing we call plantar flexion, or kind of like a ballerina toe. So you'll see this foot down here, the foot is scooped on the outer edge. It's the outer edge of that foot, that left foot, and the toes are curled down. And the foot looks like it's almost like pressing on the gas a little bit. And these are three common position changes for foot dystonia. It can also happen in the neck. So the neck can be turned or tilted. There can be this forward position of the head. So you kind of see like the neck is going forward. That's anterocallus. You can see dystonia of the face. Some people even have a grimacing pattern of their face, and people ask them why they feel uncomfortable, and they're not upset. It's just there's extra tone in their facial muscles. There's the Pisa syndrome, which is the trunk will actually tilt to the side. And so that's dystonia of the trunk. What am I missing? Anyway, there's a lot of different types of dystonia that are more characteristic in Parkinson's than in other dystonia syndromes, and that will have its own type of treatment. Dyskinesia, so again, dys, abnormal, kinesia, movement, so abnormal movement. These are very general terms, right? Kind of silly in their names. But dyskinesia is something that we'll see, and I usually call it the wiggles. So it generally will look like a little bit of a dance kind of wiggle, kind of extra movement. It is differentiated from tremor, which is very rhythmic, one directional. It's not multi-axis, and it doesn't look like a dance. It almost follows a metronome is a tremor. Whereas a dyskinesia, it's not just going to be the shoulder goes up, it's the shoulder's going to go up and around, and you're kind of going to know what generally will happen next, but you can't exactly predict like a tremor, okay? And so dyskinesia is this kind of a movement, and it is a product of Parkinson's disease and medication, so and dopamine therapy. It is not all the medication's fault, it is not all the Parkinson's fault, it is the combination of the two. And it can affect most body parts. Arms, legs, trunk, head, face, you name it. Most people who have Parkinson's will get dyskinesias, but not all. The longer a person has Parkinson's, the greater the risk of getting dyskinesias. Once a person gets dyskinesias from medication, you can make it go away, typically by lowering the medication. I feel like everything I say has except this case. So just acknowledge the fact that Parkinson's is not as simple as I'm saying. There's one kind of dyskinesia that is worse as a person's medicine is high and low, and that's not fun to deal with. But for the most part, dyskinesias are when the medicine levels are higher, and if you lower the medicine levels, they tend to get better. So additional,
Hi, I have a question on that.
sure.
So with it looks like maybe the dystonia, my husband experiences severe numbness. Is that typical? Is that the combination of Parkinson's and drugs, or is that a separate element? Because it's overwhelming for him when
Yeah.
it happens.
This is sort of it's a difficult question to answer without like actually seeing and evaluating and so forth. But I will give you a generality, which is that dystonia, because it causes muscles to overactivate, you can think about those muscles are overactivating on a lot of small peripheral nerves. And so if the nerves are kind of clamped down on, they may give an erratic signal like numbness and tingling. And so it is common to hear people describe their cramped dystonia as preceded by a tingle. Absolutely. If you read about dystonia in a medical textbook, it's not going to talk about numbness and tingling. But when you see dystonia enough, I wind up hearing about this as a feature of what happens when cramping occurs, is that a person can either feel it beforehand or during. The reason I'm hesitating is because there are so many other neurologic causes of numbness and tingling that you wouldn't want to pigeonhole yourself into that. And there may be something else going on, like neuropathy itself. Neuropathy is more common in folks who have Parkinson's disease than in the general population, and that would merit its own investigation. So I'm a little not sure what to say here, though it is common. You'd have to kind of work up this complaint from other avenues with your neurologist.
Thank
Does that
you.
help? Okay. But it's a good question. Okay. So role of additional testing. again, clinical diagnosis is made, the Parkinson's diagnosis is made based on a clinical examination. But there are testing that you can do, and it's mostly to rule out or clarify. So blood work may be done in instances where we're trying to rule out other conditions that mimic Parkinson's. So there may be cases like autoimmune conditions where we'll send fancy panels of laboratory testing to the Mayo Clinic or other areas to check for certain antibodies that could correlate with autoimmune conditions. We may want to check things as simple as heavy metals, or we may want to check things like copper or iron or thyroid. Now, if you hear me say all of those and you haven't had them done, that doesn't mean anything was inappropriately done in your case. It's just for some folks, additional blood work is necessary. Hopefully, in the future, there may be a blood test to be confident about the diagnosis of Parkinson's or not, but there is not a way to do an alpha-synuclein blood test right now. They are working on that in the spinal fluid, but I don't think that anybody I see is going to want to willy-nilly just get a spinal tap to make their diagnosis when they can have it clinically. So that's blood work. MRI of the brain. An MRI of the brain does not make a diagnosis of Parkinson's. It rules out Parkinson's mimics, okay? We cannot see the substantia nigra with enough clarity to be able to say that an MRI is specific or sensitive enough to see that part of the brain. Maybe in decades from now, when our MRIs are able to see with much higher definition and clarity, maybe that'll change, but not right now. DAT scan. DAT scan meaning dopamine transporter scan. This is a nuclear medicine test, and this requires use of a radioactive isotope. So this is a safe material to use in your body, but it requires preparation. So you go to an imaging center and you have to drink a little thing, you wait an hour, you get an injection or an IV of a radioactive isotope. You wait 3 hours for that thing to travel up to your brain, and then you take a picture that takes 20 to 30 minutes, and it highlights the area of dopamine transmission or dopamine signaling in the brain. And we can see if dopamine signaling is normal or if it's abnormal. Now, our earlier question about, well, if my DAT scan is normal, can I still have Parkinson's disease? The answer is yes, you can. You're in the single digits. It is possible. It's just much less likely. And so do I take care of folks who have a negative DAT scan but have Parkinson's? I can think of 1 or 2 cases. Yes. Where am I going with this? So a DAT scan is very helpful to differentiate cases of folks who may come in with 2 hands tremor that may be present when they're moving, like holding a cup, but not at rest. They may not have all the features of what we think of as Parkinson's. And so we may be uncertain if they have Parkinson's versus essential tremor versus another condition. So we use this test to help define if there is a dopamine dysfunction or a dopamine deficit. There are some medicines that interact with the DAT scan and can cause a false positive. So you have to be very mindful of looking at your entire medicine list and making sure that nothing needs to be stopped for periods of time. The degree of dopamine deficit. So if it's more negative than the next person, like more abnormal than the next person, does that mean X, Y, or Z about my response to medication? Right now, we don't have that much information to understand how your exact number on the DAT scan means this about your response to medicine or to deep brain stimulation or other therapies that we have, what stage you're in, or so forth. So it is very helpful in a sort of black or white feedback to us, and that we're on the right track of medicine or not. Before the DAT scan was available for use in medicine, the approach was, well, we'll treat it with dopamine replacing medication. And if it gets better, that supports the diagnosis of Parkinson's. And if it doesn't, that makes us a little suspicious that maybe it's not. Because by and large, Parkinson's of its normal variety should respond to dopamine replacement therapy more than 30%, okay, in symptom benefit. Not necessarily 100%, so we'll get there in a little bit. Now, what is not in the slide is the SIN1 test that our first question came from. So I'll just spend a couple minutes talking about that. So the SIN1 test is a skin test. It's a skin biopsy test. And so if you were to the dermatologist and had a skin biopsy where they kind of look, is that mole cancerous or not, or that skin area cancerous or not, it's that same kind of punch skin biopsy where they take a what looks like a small eraser size of skin and the few layers of skin below it. And you can do it in a neurologist's office. So the skin biopsy is done behind the neck, just above the knee and just above the ankle. And those 3 sites are sent to the lab and they're analyzed. And they're looking for a couple different things. One is they're looking at the density of nerves in that skin. And that tells us about certain types of neuropathy, small fiber neuropathy. And then it'll tell us if there's alpha-synuclein deposition. So if there's alpha-synuclein that's in that skin, it'll be telling as to if you have something called an alpha-synuclein disease. Give me 1 second. My phone, okay. So an abnormal alpha-synuclein skin biopsy is not synonymous with Parkinson's. There's another layer of interpretation depending on where of the 3 biopsy sites were abnormal. And so the reason I kind of skirted that question is because it does require a lot more discussion than that question, but it's a fair one. The skin biopsy will also test for amyloid deposition, which is a different disease process, but those are the 3 general information points that come back to us. And the SIN1 test is the newest aspect to additional testing for us. And so when that's the case, there's also a lot of, yes, we know this amount of level, but as we enter clinical practice with a new type of test, there's a lot that we learn during that process because we find ourselves in different unique situations, like what you just mentioned will happen over and over and over again, but we may not have been in that situation a lot before this test was available, right? Okay. All right, so one thing that I hear too frequently is my doctor ruled out Parkinson's disease with an MRI. So I have the situation happen that the person comes to me for the first evaluation and I'm saying, you know, I'm thinking that you have Parkinson's based on how your body is moving. And their feedback will be, I don't think so because my MRI didn't show it. But you guys have understood now that an MRI is not sensitive to pick up abnormalities that would lead to diagnosis of Parkinson's. We're just not able to see on that fine grain level of substantia nigra. So this is a myth. Oh, it would have been nice for me to show you this earlier. So the DAT scan, these are the pictures that we'll see from the DAT scan. And on the left, I think this is a little bit blurry, but on the left it says controls. And this is the brain kind of like sliced like this, looking top down. And what you see are this red area on both sides of the brain that indicate dopamine transition. And it looks like what they call the double comma sign. And that's a normal amount of dopamine. On the right over here, this is the brain of a person who has Parkinson's. And it's what we call the double dot sign, or there is an attenuation of dopamine signal on the tail on both sides of this deep part of the brain. And this is what we call a dopamine deficit. When you look at the report of a DAT scan, It does not say that your dopamine is low, you have Parkinson's, and we're done. It says you have a low dopamine level, which could be consistent with Parkinson's or other Parkinsonisms like PSP, CBD, MSA, DLB, and a whole lot of other alphabet soup diagnoses. And that's because an abnormal DAT scan is not specific to Parkinson's. It is true that by chances, it's the most common thing you may have, but it is not specific to Parkinson's. Okay, so it still requires a thoughtful process from your neurologist about, okay, is it Parkinson's or is it an atypical variety that has a dopamine deficit? Okay, I hope that's clear. What else? I think all those bullet points we talked about. Any questions here? All right, so moving on. Parkinsonism. Parkinsonism is a descriptive term. So it describes slowness, stiffness, walking imbalance, plus or minus tremor. It's just basically, you can say Parkinsonism and mean those things, okay? Parkinsonism in and of itself is not a diagnosis. It's a describing term. Under that description of Parkinsonism, the most common thing to have is Parkinson's disease, which will have more prominent one-sided symptoms. It'll typically respond to dopamine medications, and it'll follow this more classic course. If there's any of what we call red flags, which are atypical features, like there's early memory and thinking difficulties, there's early falling, there's double vision, hallucinations, periods of altered mental status, early swallowing dysfunction, a whole host of other things, then we wonder if we're in the category of atypical Parkinsonism, where there's these atypical features, and so we're not actually under the umbrella of Parkinsonism, Parkinson's disease, we're on this right side. And these four major atypical Parkinsonisms have their own clinical course, their own kind of response pattern to medication. All of the ones on the right can actually come back with an abnormal DAT scan. Some of those on the right can come back with a positive or a negative abnormal DAT scan, the first two I mean. So it gets to be kind of confusing. On the left, the vascular Parkinsonism and medication-induced Parkinsonisms are two things we haven't talked about yet. So just briefly, vascular Parkinsonism is a person who has got slowness, stiffness, a walking pattern change, but their MRI actually shows a lot of what we call vascular changes to the brain. And they may have hypertension, meaning high blood pressure, high cholesterol. They may have had strokes or other things that cause the brain tissue itself to have these changes. And then you think about this interfering in dopamine transmission. So they look like they have Parkinson's, but they don't. Medication-induced Parkinsonism, so I alluded to this before. There are certain medications that treat different mental health conditions that block dopamine. Well, if you take a medication that blocks dopamine, it'll look like you have Parkinson's. Most of the time, it's medication-induced Parkinsonism, so slowness, stiffness, and tremor from that medicine. There are very complex cases where it can be both, but again, in simple terms, medication can cause Parkinsonism-like features. And both medications used in the mental health arena, as well as some anti-nausea medications. If you have Parkinson's, it's important, if you are going to take a medication for mood or for nausea, that you tell your doctor, does this one cause Parkinson's symptoms? Because there are certain ones to avoid, and there are many more that are very safe and should be used, but is important to clarify. All right, questions before we move on to non-motor symptoms? People are not as courageous about interrupting when you're on Zoom. It's such a funny thing. All right, anybody?
I have a
feel free.
question.
Please.
So how do you parse out if a nausea medication or um, a blood pressure medication is causing a symptom
Yeah, so you
versus
have to ask your
not?
doctor. There's just a list of medications by their mechanism of action, by blocking dopamine, they can cause it. But for example, ondansetron, which is a very safe anti-nausea medication, also known as Zofran, has no dopamine blocking properties. So you kind of have to go through your medication list and ask your doctor. And if there's any hesitancy, you can also ask your pharmacist. But it's a very clear, like black and white, this causes it or this doesn't.
Thank you.
I know not everything's easy in what we're talking about, but that one should be actually very easy to go through with your doc. All right, non-motor symptoms. I said before that it feels like for movement disorder doctors who treat Parkinson's that we feel like we're a primary care doctor sometimes. And the reason is because of all these non-motor symptoms. If you read this list, this is pretty much that so many different avenues of body function that are affected. So anosmia, which is loss of sense of smell, this can precede motor symptoms by decades. Constipation, another thing that can be there before a person has slowness or tremor or whatever motor symptom by decades. Urinary frequency and urgency. People have this very strong urge of needing to get to the restroom, and then they start to walk slower and it gets harder, so it can lead to accidents. Of course, not all of these happen, but these are just possibilities. So when I'm reading this list, and if you have Parkinson's, you can either silence me or you can just understand that these are possible, may not happen. Hopefully they don't, but if they do, you can talk to your primary or you can talk to your movement disorder doc about, is this related and what can I do? Because all of these can be treated with medications or other sorts of treatments that are non-dopamine therapies as well. REM sleep behavior disorder. So REM sleep is that part of our sleep where we have rapid eye movements. Rapid eye movement, REM, that's what it stands for. When it's disordered, we have rapid eye movements and do all our dreaming, but we're actually moving around instead of being in what should happen, which is a semi-paralyzed state. Just our eyes move and we dream in our head, but we don't act out with our body. And when it's disordered, we act out with our body. And so if we have a very frightening dream, like a bear chasing us or somebody trying to hurt us, we're going to get them. And sometimes we'll get the other person in the bed or we'll hurt ourselves and get a lamppost or something. I don't know who has a lamppost, but a lamp. People hurt themselves all the time with this condition. Or they wake their partner up and their partner is wondering what in the world what are they doing? This tends to happen in the later sleep hours. So after 2 a.m. And it's common that they're threatening dreams. And it's common that they're very vivid and very real. Not everybody has this dream reenactment, but if it does, it's very serious to talk about your doctor with. For some people, they're just mumblers and they wake up and they didn't like what they dreamt about. But for other people, you can get hurt. And so it's important to talk to your doctor if this needs to be treated or not. Restless leg syndrome. So that's a feeling of when your legs have an unusual sensation and you really need to get up and walk around to make that feeling get better. This can happen in the nighttime, in the morning time. It can happen with or without Parkinson's. Cognitive changes. This is a big one. It's not so cognitive, meaning memory and thinking. And it's not the typical, oh, I have short-term memory problems. It's more of a, I have difficulty multitasking all of a sudden. I'm having trouble if I'm in the middle of, working on my calendar or whatever I'm doing, my emails and the phone rings. I have difficulty getting back to that. I have difficulty being in a loud area and processing conversation that happens quickly. I'm less participatory in conversation because sometimes it just feels like it's coming at me too fast. Some people have word finding difficulties. So that tip of the tongue, what was that actor's name? What was that street's name? But that can also happen as we get older. So then it's sort of, well, what's what? Is it age or is it Parkinson's or something else? Parkinson's can progress to dementia. It can also progress to what we call mild cognitive impairment or none of the above. So the degrees of memory and thinking changes that happen are also individualistic. It is not always an expectation that everybody will progress to the point of dementia. Absolutely not. Thinking of other cognitive changes that sometimes we don't say. One that I feel is very hard for people is when there's a latency, there's a pause before they speak. So if you're asked a question of, do you like this vanilla ice cream? And yes, I like this vanilla ice cream, right? Like that really long pause is something that can happen too. And it often makes a person feel a little bit uncomfortable, or the person that they're with who is now just saying, yeah, you liked it. Don't you remember? So people will always, not always, but people will often start to talk for a person who has Parkinson's because of that pause. So there's a lot of work that can be done with the speech therapist for the person who has Parkinson's, but also for the person who's with them that's talking over them to help kind of work on conversations. Hallucinations.
I'm sorry, I do have a question on that.
Yeah, go ahead.
So that is an extremely difficult area because my daughter and I live with my husband who suffers from this. But it's so hard to communicate to other people, like, give them a minute, right? And to without diminishing him, kind of step in and say, hey, be patient. This is real. And I just don't know how to communicate that to other people who are impatient, who are not accustomed to that pause in speech.
Yeah, I mean, I feel that you can prepare the loved ones around you really well, right? Offline of the conversation. And that is probably an easier thing to deal with. But in the grocery store, for the person who doesn't have the patience to wait, that's going to be much more difficult and much less modifiable. One suggestion is to work with a speech therapist who is Parkinson's trained about techniques to help a person insert themselves into a conversation. The other thing is to give that person yes, no question, or yes, no questions. So they're not spending time formulating the response, but a yes or a no is a shorter utterance that may be easier to come up with.
Okay.
Ultimately, in more stressful situations that are typically not with the family, but out in the community or in a restaurant or something, those are much more high stress situations. And that exacerbates that pause.
And it causes avoidance of those situations, in my experience.
Bingo. There's this other part of Parkinson's, which is this underlying mood change that can happen. Oh, it's 2 bullet points down. So mood changes, and in particular apathy. So this quality of, it doesn't matter. You know, I don't have the motivation to do X, Y, or Z that I used to do. Also, the response to symptoms sometimes comes across as apathy. Well, the person didn't understand me. They actually don't care. And you may care as the wife or the daughter, but the person may not care as much. So that's an interesting spin on it. That's probably less likely in this situation, and it's more apathy to other things than that aspect of conversation. But there are changes in a typical mood response that happen. Anxiety is very common. Depression is very common. And it's not a reflection of their response to the disease, meaning, oh, I was diagnosed with Parkinson's and now I'm depressed because I have this new neurologic condition. And don't get me wrong, all of those feelings are warranted. You have the ability to react to a new diagnosis however you want, quite honestly. But, well, within means, okay. But what happens in Parkinson's is there's also chemical changes in the brain that create anxiety and depression, irrespective of how you feel about a new diagnosis or your response to treatment or your family's response to your diagnosis, yada, yada. So people are often approaching anxiety and depression with a lot of stigma in this world about, I don't need another medicine from you. I don't need to treat that. I'm going to tough it out. I'm going to do it. But you're less equipped often in Parkinson's because chemically in the brain, things are just different. And so just like I showed you the DAT scan where dopamine is dysfunctional, what if there is other neurotransmitters like serotonin, acetylcholine, norepinephrine, which these are dysregulated in the brain, and they can cause some mood changes. We sort of have this discussion of, well, knowing that, wouldn't you want to treat those too to help you feel better? So there's a lot of different understandings of emotionally how people are dealing. The last part of it, impulsivity. People may not have this same filter, we call it, they may be more disinhibited. Instead of sort of like thinking about things for a second, they're just kind of running and doing things. And that can happen when a person is at a fall risk too. All of a sudden, their filter of maybe I shouldn't be doing this is just gone, and they're off and they fall because they are not responding to that typical, self cue that you need to be careful, you're imbalanced. Impulsivity can also be seen in other areas of functions such as gambling, shopping, eating, sex, a whole bunch of different things. People can be impulsive. People can even be impulsive with their medications and over-medicate. So this becomes a very important aspect to talk about, and a lot of people don't like to talk about these things. Like all of a sudden, yeah, they've got this new diagnosis of Parkinson's, but now they're spending all their money. And you think about dopamine as one of these reward circuits. It's one of these circuits in the brain that is triggered when a person does gamble or does get a reward from a thing. Dopamine is involved. And so if it's dysregulated, a person who typically is very frugal may all of a sudden start shopping. And that is very important to talk with your doctor about because they can help typically by avoiding certain medications or changing medications. Not always, but it's important that they know and that they walk you through this process. And again, that's not that would happen with everybody, but when it does happen, nobody thinks to tell their neurologist about this thing. So that's why I make a point to tell you guys about it. Orthostatic hypotension.
I'm sorry, I do want to mention
Yeah,
something
please.
there. Just on your comment about, talking to your doctor about this. I encourage my husband to take notes to discuss it with his doctor, but I'm not working. So I'm not there to support in that effort. And I'm fearful that experiences that he's having are not being chronicled to share. Is there any tip to doing that besides taking voice memos?
Join the visit by phone,
Oh, okay.
FaceTime into the visit, even if you're working, if you can take that like shorter period of time to join virtually, that I found has been really helpful for some patients. Sometimes people will send a letter before their loved one comes to see me of like, here's the things we have to talk about, and here's the things that probably he or she is not going to mention that I need you to know about. That's been helpful. To that person's credit, like to your husband's credit, what I would say is these doctor's visits are very overwhelming. It's like all these things all at once. And so they really do need somebody to help them, to take notes for them or to remind them to talk about these things. And if that's not possible, because just like you said, well, I work, then to come up with a rubric or a list, because you have a defined amount of time to get your mission accomplished, and you want to be as prepared as possible. Okay. I'm sure other people have very good ideas about that, but that's just what I've seen thus far. And I do know that I don't get the whole story from somebody who's there alone. So we get that too. That's why I love when people come with an entire room full of people. I'm like, the more is merrier, because I know every one of you has your own version of what's going on here. Okay. Trying to minimize this thing again here. So orthostatic hypotension, this is low blood pressure with standing. This is common to see in folks who have Parkinson's, or is present with folks who don't have Parkinson's. So if you think about laying down on a bed and in the morning you stand up quick, well, you get dizzy. That's one of the big hallmarks of this, that a person who goes from laying down to standing quickly can get dizzy. Or you go tying your shoe and then you stand up, all of a sudden you can get dizzy. It would be really interesting to see what your blood pressure is like when you're laying down and compare that to your blood pressure when you're standing. Some people drop like 70 points. It's pretty remarkable, and that can be fixed. If a person's on a blood pressure lowering medicine, we may get rid of it. There are a lot of people who don't hydrate as well as they should, so we may encourage hydration or even salt supplementation. There's a lot of different ways to make a person feel better. Some people have no idea this is happening and they just pass out. So it's important to know that a person who has dizziness or passing out or headaches, or they all of a sudden start falling, blood pressure is something we're going to be asking about. Fatigue. Fatigue is one of these non-specific, non-motor symptoms. We know there's a higher risk of fatigue in Parkinson's. We just can't put our finger as to like why that happens. So we usually ask the primary to check the thyroid and check the heart and check the lungs, and are you sleeping, and is it your medicine? There's a whole lot of things that we talk about to sort of see if there's any part of it that is fixable. Drooling typically will respond to dopamine medication to some degree, and if there's still drooling that's there, there are some injection therapies or other under the tongue droppers that we can treat for drooling. Sexual dysfunction can happen. Erectile dysfunction can happen with age and other vascular conditions, but it can happen in Parkinson's too. Skin changes. Melanoma is more common in Parkinson's. Also some other tan patches of skin pigmentation changes that a dermatologist really needs to see you for. So if you don't have a dermatologist and you have Parkinson's, and especially if you live in Colorado, where we get more sun than some other folks, you should be seeing a dermatologist for a skin check, and the dermatologist will know that you need to be checked closely because the risk of melanoma is higher. Shortness of breath. There's an association that has a long discussion behind it. We'll leave it at that. Sweating, people can have bouts of excess sweating. Pain, kind of like fatigue. We know it's more prominent. We can't kind of put our finger on it. There's can be a number of different causes. And then neuropathy, or the smaller nerves as they get to the furthest parts of our body, like our feet and our hands, they can be numb and tingly. And that is not always accompanied by dystonia, like we talked about earlier. This is a study out of our movement disorder journal that is very interesting. 98% of individuals with Parkinson's had non-motor symptoms at any, in their disease course, had at least one of those on the prior slide. The average individual had 8 different non-motor symptoms. And as a person goes on in years with Parkinson's, there is a greater chance of getting another one and it being more severe. And most often in the psychiatric domain. So that being mood changes, impulsivity, hallucinations, cognitive changes. I think I actually skipped hallucinations because of a question maybe that we got, but we're going to skip them now. All right, it's 5:16. Let's take a little break. I don't know, Phyllis, what you want to do in terms of timing.
Is 5 minutes good? You need a little more than that, or
That's fine for me. We can do that.
why don't we, it's 5:17, why don't we start back up at 5:22?
See you then.
That was great, thanks.
Will there be a recording of this available to us at a later date?
Yes, there will. I'm recording it right now, and I'll load it on YouTube, and it'll be available on our website. I'll also send it out. Once I have the YouTube link, I'll send it out to everyone who is registered.
Wonderful, thank you.
You're welcome.
I just want to let you know that my husband is a member of the HOA for a condo, and they're having all sorts of problems that he needs to address, so I'm gonna have to leave at 5:30. I don't want to, but he gotta address these problems, so I just
Oh
want
my
to,
goodness.
I'm sorry.
We'll get the recording out to you so you can catch, what you missed in the end.
Okay, I'm really sorry. I didn't know there was gonna be a meeting,
Understandable.
so I'm sorry. I'm loving this, loving every minute of it. I'm learning all sorts of stuff.
It's
Oh,
very
that
interesting,
applies to
yes.
me. That doesn't apply to me. That type of stuff's good. Good, good, good. Go ahead. I'll shut up now.
Hey, Parkinson's Association, what's your first name?
My name is Phyllis.
Phyllis. Okay, this is Joe. I asked Dr. Solis the question earlier about the relationship between the DAT scan. Oh, there's Dr. Solis. Huh? The relationship between the DAT scan and the SIN1 test. Dr. Solis, I'm currently working with Dr. Salinas at Rocky Mountain Movement Disorders, and I'm going to see her tomorrow to discuss this. But I'm feeling as if I might need a second opinion. Are you taking new patients, and would you be open to me talking with you directly through formal channels?
Absolutely. But I will tell you that Dr. Salinas is a very good movement disorder specialist, just so you know.
Thank you, and I appreciate that. I agree with you. I'm just I'm concerned about like being pulled in and out of a clinical trial, and
Yeah,
and I learned something new from you today that I didn't hear from her, and stuff like that, and that's why I would sort of ask questions about I've been thinking about getting a second. It's so nebulous in terms of like how you guys do this, and I feel like I probably need to get a second opinion just so I feel comfortable as well.
you're very welcome to.
Okay, thank you.
Mhm.
I have a similar concern. My husband is seeing a specialist who focuses on migraines, not on movement nor PD, and our wait list for a local specialist is June, yet he is bursting with symptoms. And I'm I'm flummoxed as how we can get him to see somebody who can address his specifics more quickly.
That's a problem because there's not only a shortage of neurologists nationwide, but there's an extreme shortage of movement disorder specialists, especially as the population ages, and every year we need more, and we don't have them. So that is a big problem. And I don't have a good answer for that one. I would say if you're dealing with the situation of Parkinson's, that is not just, I take the medicine, it works well. If you've got a number of motor and non-motor symptoms, if this is getting advanced and not responding to medication, then it does need a movement disorder specialist. I think it is worth the wait of getting in. That's the hardest part of getting in to see somebody like me, is that like initial wait. And that's because I have to take care of the people that I take care of already. And I think all the other neurologists would say that as well, who are movement disorder specialists, is that we're sort of vested in taking care of our patients as much as we can. But I agree, it's a huge problem.
Yeah. What I was told is that the Boulder County area has a fair number of resources, but I'm not quite sure where to look for alternative movement disorder folks. Is there a specialization that I should seek with my insurer?
No, so you're looking for a neurologist who's a movement disorder specialist.
Okay,
That's what you're looking for.
thank you.
Mm-hmm.
Elizabeth, this is Joe. I try Rocky Mountain Movement Disorders in Englewood. It's Swedish. But I didn't have any problems getting in. I've been seeing them since September, but like Dr. Solis said, Dr. Salinas is really good, and they've been wonderful to work with so far.
Thank you. Yeah, my hope was to perhaps not have to travel so far, but my my husband needs care more than I need to reduce commute.
I know that the university group does go to Boulder So the University of Colorado at Anschutz, that their docs do have a satellite clinic in Boulder. I don't know what the wait time is to get into that though.
I'll certainly explore that.
Yeah. Okay.
Well, folks, I'm afraid I have to go. I'm sorry to miss the rest of you. I'll see you next meeting.
Okay,
Thank
we'll
you
get
so
the
much,
recording
Dr.
up to you.
Very helpful, very, very helpful. I took a lot of notes. And I'm sorry I have to leave. Thank you so
Another-
much. Go ahead.
Yeah. Another thought about movement disorder docs, in Lakewood is Nicole Licking, Licking. I don't know what her wait time is either. But she's at least, I don't know how close with Lakewood is to you, but there's that. All right, let's
Hi
finish.
there. I just wanted to chime
Yeah.
in. I'm so sorry to interrupt. I'm Christy from the Parkinson Association of the Rockies, and Dr. Licking is actually going by Getzel now. It's like pretzel, but with a G. I think it's a married name.
Oh,
And
right.
yeah, and she
Thank
has moved
you.
up to the Boulder
So
community
she
hospital
is
area.
in Boulder now, huh?
The last I heard, she was.
Oh.
Yes, that should be correct.
How do you
Thank
spell her
you so
last name
much.
since she got married?
It's Getzel, Getzel. Oh, someone put it up there. Hello.
Oh,
And she
thanks.
is in Boulder, because I'm seeing her tomorrow.
Yay, thank you.
Perfect.
Thank you, David.
This is such I learned too. Well, if you're seeing her tomorrow, tell her we all say hi and congratulations on getting married.
No problem.
Okay. All right, so let's keep going. So treatment options. Now, I'm not going to talk about all the medicines that are available in Parkinson's. I think somebody else will be doing that next month, probably
Right.
Dr. Hawkins.
Yes.
But what we are going to talk about is the different kinds of treatments that are there. So there is something called disease modifying therapy. And this is something that modifies or changes the disease process, right? So it can either slow it or it can revert it, meaning cure it. And we don't have anything that cures Parkinson's right now. The closest we have to something that slows it is exercise. So in disease modifying therapy, there is exercise, but there is no medication that slows progression, okay? Symptomatic management refers to treating symptoms, and our medications do that. They treat symptoms. They treat slowness, tremor, stiffness, walking sometimes, but those do not reverse or slow the disease course. And that is very important to understand because let's say you start medications a year later than your neighbor who has Parkinson's. That doesn't mean your disease is going to progress faster or be less responsive to medicine. That just means that you had 1 year less without symptom management, 1 more year of, let's say, tremor, right? But it is still your decision about when to start medication. And typically we'll say, start medication when your quality of life is impaired by these motor symptoms or potentially non-motor symptoms. So I don't think enough emphasis is placed on exercise. And my last talk on this topic, I think only had 1 or 2 slides, so I added some extra this time. Because exercise in Parkinson's disease, again, this is the only way that you can help your own course of progression slow down. It's very important. It should be a prescription. It's that important, okay? Exercise in Parkinson's is also helpful from multiple different angles. In addition to slowing this progression, we talk about managing symptoms. So if you think about exercising, it helps strengthen balance, right? It can also help non-motor symptoms. People who exercise may have less constipation, or they're helping release their own dopamine and they're getting a mood burst, other feel-good attributes to this, right? People who exercise may be less likely to avoid isolation, have lower stress levels. And if you exercise with a network of other people, develop this sense of community that's very helpful. people always ask, what should I do? Should I do boxing? Am I gonna go start swimming? And there's a lot of exercise-based research about this in Parkinson's. The general consensus now is do what you like because we need you to do it long term. So I met somebody today who was doing Zumba, and he said, I hate Zumba, but I'm doing it because I think it's going to be the best. And I said, well, you don't have to resign yourself to doing Zumba if you feel like socially humiliated by doing Zumba. Do something that you like, because I don't want you to resent this part of your prescription. Turns out he actually liked Zumba and he was joking, but anyway, don't torture yourself by doing something you don't like. Make it fun, make it something that you want to do it on repeat, because that's what we need, okay? Think about your exercise is more important than your medicine, even though it may not seem that way to you. So even though there's literature that suggests that Tai Chi is better for balance, and there's role for high interval intensity, and people who do Pilates have this, and you may do boxing because of this, and if you think when you're doing the movement that this is going to happen, it doesn't matter. What happens is that you do movement. That is what's shown. Okay? All those other layers of complexity are not as important as you moving. So if that means you walk your dog and you're not letting your dog smell on every corner, then you're doing okay. You're good. I highlight PAR here because there is their own YouTube channel. And on the YouTube channel, there's a lot of videos that are prior webinars like this about exercise and why it's important. So if like 5 minutes from me wasn't enough, you can listen to more about why exercise is important, and maybe how to get into exercise if that's not something that you're doing. Because again, most important thing to take away from this is that this is what we need you doing. There's also classes that are on the Parkinson's Association's website about different kinds of exercises at different levels. And maybe you can meet other people, or maybe you don't like meeting other people and you want to do it at home. There's virtual options. So go on the website and explore and challenge yourself to try one of these. And PAR did not make me say this. Here's a really compelling illustration. So this is looking at curves about what happens to people who exercise and people who exercise before their diagnosis, right after their diagnosis, or who didn't exercise. And if you compare red, which is the traditional course of Parkinson's disease, to any of the other colors, black, blue, or green, all of the other flavors of exercise, either people who were exercising way before their diagnosis or who were diagnosed and then started it, the folks who were exercising have a more shallow degree of disease course. They have less motor symptoms, less non-motor symptoms, and a better quality of life on all those domains. And so it's very important to kind of look at this in a schematic form of you're doing a whole lot for your disease condition by dedicating 150 minutes a week to exercise. And that sounds like a lot. And if you're doing 0 now, it would be worth working with somebody on how to build that up. Segue to rehabilitative therapy. So you guys may have heard of Big and Loud, which is a Parkinson's directed physical therapy, occupational therapy, and speech therapy. Sometimes you'll hear of it as LSVT, Lee Silberman voice treatment, which is what this therapy is predicated on, this technique. And I copied part of their website and put it here for you. If you go to lsvtglobal.com and you go in the right upper corner, it's kind of hard to see, I don't know why they put it there, but find LSVT clinician, click that. It'll take you to this screen where you can put in your zip code and that you want to either find speech or physical or occupational therapists. And it can give you a list of folks who have Parkinson's certification in therapy. And so you can find like a Parkinson specific one. What it spits out is not always clear though, because sometimes it'll actually give you an inpatient physical therapist, meaning they are doing inpatient in the hospital therapy and not just outpatient. But it's a good list that maybe you can bring to your neurologist and say, like, these people have extra accolades. Do you like any of these? Do you think any of these would take me? Because often it's like, who should I go see? Who do you recommend? Physical therapy can be helpful for people who fall, who need to use a walker and don't know how to do it, or people who don't really seem like they need physical therapy but have not been exercising and have no idea where to start. They may benefit too. Or people who need to just learn the techniques of focusing on big and loud motions to help modify their symptoms to some degree with therapy rather than all medication.
I have a question on this.
Yes.
So, clearly all of this healthcare has a cost associated with it.
Mhm.
And if you, are any of these pieces generally covered by Medicare?
Yeah, big and loud is.
Okay.
And
My
working with the
husband's
physical
not
therapy and
of the age to receive this yet, but this is clearly taking a huge chunk of money without Medicare.
yeah, so the caveat is what your copay is, right? Typically some of these things are not some of these things. Typically physical therapy and occupational therapy and speech therapy are approved therapies for folks who have Parkinson's. But it's what your out-of-pocket expense is for your copay, that's dependent on your insurance plan. They are covered by Medicare and Medicaid, but the cost that you are responsible for, that's more of your insurance.
Right. And I think just, we're at, scripts and PT and mental health therapy and
Yeah,
adding,
expensive.
just, it's all just
Absolutely,
overwhelming
absolutely.
and expensive.
I don't disagree
Elizabeth,
with you.
yeah, Elizabeth, it might be helpful to consider connecting with me. I'll try to email you. I'm Christy from PAR, and there is some information about chronic conditions, and there will be some chance to advocate for some of that in the near future, next week, as early as next week, if you're interested, for some of that with our state capital legislature. So I'll happily send some information on to you if you're interested in that.
Thank you.
Dr. Solis-Cohen, I had a question on the chat feature about exercise. Bill asks, which is better, aerobics or anaerobic exercise? Apologies if you answered that already.
Oh no, I laugh because we just don't know, Bill. So I think it's a great question, and I think that if you look at the exercise literature in Parkinson's, there's a lot of back and forth about which one is better. Is there really one that's better? And I don't think we have an answer that is as black and white as what you're looking for. Christy, can you also send me what you were going to send our listener as well?
Absolutely, yes.
Because I think that you're alluding to something that may be helpful for me to share.
Yeah, absolutely. I'll send that
Thanks.
to you.
And as an aside, the Chronic Care Collaborative, which I used to refer people to, that's still not a thing, correct?
No, that's actually what the group that's leading this
They're
day
coming
at the
back to
Capitol.
life because they ended.
Oh, interesting.
I tried to enroll somebody a few months ago and they told me that that was dismantled.
I wonder what's happening with that, because I will send you what we
Okay.
have. Jody and I will be at the Capitol next week.
Okay.
So I'm happy to send that to you.
That was a fabulous program that I had folks benefit from too, and I was very upset to hear that it was done. So if it came back to life, hooray.
It could be that they've just moved kind of the needle. I don't know, but I'll send that on to you.
Yeah, I'm interested. Thanks. All right, let's see what we have time for. Another really great resource that I share with a lot of my patients is the Parkinson Voice Project. And this is a nonprofit organization where you can do speech therapy virtually. And you can either work with a therapist who's live there across the camera from you, or their pre-recorded sessions that you can practice with. And so just today, I had somebody who said my insurance only covers one session of speech therapy a week, but I really benefit from this and I really want to do it more, but I can't really do it by myself, just shout there in the room. So what do you think? And I shared this, and they came, and people come back all the time liking this work, and it is free. So another great resource, just write it down. It's parkinsonvoiceproject.org. Okay. They have a lot of also like educational videos too, like PAR does, but go to them for the speech aspect. All right, I'm gonna fast forward through some of this stuff. How do Parkinson's medications work? So if we have a lack of dopamine in the brain, it would make sense that the treatment of that condition would be to help increase dopamine in the brain, right? And so how could we do that? Well, we could make more dopamine. We can give the precursor to dopamine. We can activate the dopamine neuron itself. But there's a lot of different mechanisms of action. And that's how our medicines work. They work typically on creating more dopamine levels in our brain. And these dopamine medications typically help with rigidity, stiffness, slowness, tremor, but they don't help the same symptoms for everybody. So when a person starts medication, typically we'll ask them, what happened? What happened since you started medicine? And it's not because we don't know and we're just being facetious. It's because, one person may say, my tremor got better. And another person may say, I'm walking so much faster when my tremor is still there. And so we'll have different responses from different folks. It's very important to be open and honest with your doctor. It's important to tell them when you're taking your meds, how many doses you miss, because some of these are 3 times a day, 4 times, 5 times, and so forth. It's important to take your medications on time, and it's important to know what symptoms you have and how they relate to your medicines. So for example, if you have a tremor that sometimes gets better with your medicine, but is there at other times, your doctor may say, well, does it get better with your medicine and then the tremor will come back as your medicine wears off? So it's important to know how these symptoms relate to the timing of your medicine. The most common medication that we use in Parkinson's is carbidopa-levodopa, and it's been used for more than 50 years in treating Parkinson's. Levodopa, the second ingredient, is basically an amino acid, which is a protein building block. So it's kind of as natural as you can get for treating Parkinson's, even though it is a prescription medication. This medicine is a pill that you take typically without food. So you take it on as much of an empty stomach as you can. It goes down to your small intestine, gets absorbed there, goes to your bloodstream, and then crosses the protective surrounding on your brain called the blood-brain barrier. And in your brain, it's recognized by an enzyme that you have. A natural protein converts that levodopa to dopamine. And so by giving yourself the precursor to dopamine, you'll make more dopamine. Again, there's an individualistic profile to motor symptom improvement. Carbidopa is always given in conjunction with levodopa. Carbidopa helps prevent some of the side effects that would occur if you took levodopa alone. So if levodopa breaks down in your bloodstream or other parts of your body before it gets to your brain, it can cause things like nausea, vomiting, lightheadedness, low blood pressure. And then in other aspects, it can cause things like confusion, hallucinations or those extra wiggly movements we talked about earlier called dyskinesias.
I have a question from the chat.
Yeah.
Sandy asked, besides meds, is there any way to increase dopamine such as certain foods?
So yeah, there are some dopamine containing foods, but again, we're talking about the need to cross the blood-brain barrier. Okay, so that just because you'll increase foods in your in your body doesn't mean that that aspect is going to go into your brain. And also the quantity that crosses is far less than what you would need to make a motor function change. But it's a good question. Okay, so levodopa, and I should say that there is a supplement called mucuna pruriens, and that is, I think, coming from some sort of bean that has a higher concentration of dopamine in it, but typically that's considered to be very weak potency in terms of motor benefit than giving even a low dose of carbidopa levodopa. Carbidopa levodopa just enhances the bioavailability, so the availability of this medicine to your body and then to your brain where it needs to act. So yeah, the blood-brain barrier gets in the way of what we think would be an easier form of treatment. Carbidopa levodopa is so widely used that there are so many different forms of it. As you can see here, the most common is this immediate release, which is on top, we often call Cinemet. And then there's newer forms that you can see in this list. I'm going to leave this to Dr. Hawkins, who's going to talk next month. But I will just tell you that it is so widely used that just in the past year, we have had 2 new medications with carbidopa levodopa iterations coming out. So pretty, we just can't get over it. It works well. Now, everybody asks about what to do in terms of eating with or without your medicine. Do you eat before? Do you eat after? And this is a thing to really discuss with your doctor one-on-one. The standard medical textbook answer is avoid protein with your meals because you will absorb less medication. And so you want to take your medicine 30 minutes or more before and 60 minutes or more after your meal. That says it's kind of funky, but yes, give yourself as much of an empty stomach as possible. You can ignore this recommendation if you eat a large protein meal and you find that your motor function is no different, because if you absorbed, just a little bit less with that dose with your high protein meal and didn't affect you, bring that to your doctor's attention. I've had people who they don't have as many signs of wearing off and kicking in, and they've been eating so little that they were actually starting to lose weight, and they weren't getting proper nutrition. So it is important to get your nutrition in and to take your medicine. So if you're kind of confused about what to do in your particular circumstance, bring that back to your doctor. It's not always as simple as the medical textbook answers. And I, not infrequently, will tell people, you are one of the people that can ignore this rule. You must abide by this rule. In fact, you have to abide by this more than other people. So it really depends on a person's disease process, what they have to do with this. That's my personal take on it anyway. This is a myth. Parkinson's medications stop working after 5 years, so I should delay starting treatment. This is something that if you read medical text from books from more than 20 years ago, you would see in there. And most of the time in neurology now, that myth is dispelled, but it was something that was actually discussed in the 90s. So we know that medications work and that early use of medications did not impact disease progression, motor fluctuations, and how early dyskinesias start. And there's a delayed start trial of levodopa and Parkinson's disease from the New England Journal of Medicine. Additional investigations on this show that there's better quality of life ratings for folks who did treat their Parkinson's earlier.
Dr. Solis,
Yeah,
I've got a question for you. I'd like to get your opinion on this.
sure.
I'm 72 years old. My sister has been diagnosed with Parkinson's. Hi, Linda. And I have high blood pressure. I went down this road to try to find a natural cure for that. And I went into the rabbit hole. It's called the carnivore diet. You're talking about food. Many carnivores, and a subset of that, or that's really a subset of keto, of being a ketogenic or a ketogenic diet, low carbohydrates, you know, and if a person stays in ketosis, 20 grams of carbohydrates or less a day, your body changes from burning glucose, sucrose, and fructose and turns into a fat burner. And when it turns into a fat burner, it doesn't produce ketones. And ketones is like a superfood for the brain that helps the
So
brain
you're-
connect neurons.
You're correct to say that, like, what they call this nutritional ketosis. So there is a promise for treating Parkinson's disease in this based on some small cohorts of folks who were studied in Parkinson's disease. The data is not conclusive enough for me to say in a Parkinson's 101 talk that everybody should follow a ketogenic diet. You're not wrong to say that there's a lot of hope out there, but I can't say it in this kind of a realm with the degree of data that exists. It's just not enough for me to kind of outright blanket say that to everybody.
No, I
Is that
totally
fair?
understand that. But when you jump into that carnivore community, there's huge communities and they have questions and answers, and numerous people have been on those communities. It reverses diabetes, it stops dementia, and people with dementia have reported recovering from dementia. And Parkinson's is somewhat like dementia because of the glycation and the alkaloids that are plaque that is created in the brain. So isn't there some kind of a correlation there? Wouldn't you want to provide your brain superfood so that the neurons are connecting and your brain is growing rather than disintegrating?
Yeah. So again, it's my job to present you with like the most evidence-based data. And I'm not here to like dispel, you know, what your thoughts are at all, but I can't confirm them on a level that's evidence-based right now. But there are people who will suggest to follow an intermittent fasting diet to do this, that, or the other. The most rigorous data comes out from the Mediterranean diet, actually. And the Mediterranean diet was studied in folks who had what they call prodromal PD, or they had non-motor symptoms that they were going to get PD. And I think they had an abnormal DAT scan, and they watched these people and took them and watched how long it took them to convert from a prodromal state to Parkinson's, and the Mediterranean diet was thought to be helpful. But again, it's the level of evidence that is important for me to recommend to a group like you. So I'm just going to leave it there. Okay. For the sake of time, I'm going to skip motor fluctuations because Dr. Hawkins is going to do that, pretty sure. And that requires a lot. Let's see what else is left. 1 second. Okay, so who wants to hear about motor fluctuations and who wants to hear about advanced therapies? I think we have time for one or the other, but not both.
I'm interested in the motor fluctuations in as much that, you know, when the
All right,
off time is indicated, can you take your dose earlier than is recommended? If
Okay.
the symptoms start showing up earlier than the dosage timing.
Okay, so let's do that, and then we'll leave advanced therapies for the next talks. So motor fluctuations, you'll hear a lot of people say off and on. And what does that mean? So on is when a person has motor symptoms like slowness, stiffness, and tremor. Those symptoms are improved after a dose of medicine. They're called on, in the on state where the medicines are working well and the medicines are on. After an on state, if the medicines stop working again, they can be off, or those slowness, stiffness, tremor symptoms return. Off symptoms can be present in the morning as well after a longer time between a person's dosing. So that's on and off. Now, not everybody cycles into on and off states, but a lot of people do. And the more times they transition from my meds are working well and I'm on to now my meds are not working well anymore and I'm off, and they go back and forth and they feel like they're on this roller coaster, the more disturbing their motor symptoms can become. Sorry, guys. Okay, so this is a schematic to talk about that and kind of follow a graph model here. So on the y-axis, we have people who are below this line. Their symptoms are not controlled, so they are off. So below this black line here, these are folks, or these are periods when you're having your tremor and your stiffness return. If you're above this line, on this side, above this line, you are having adequately controlled on time. So this is a depiction of a person's day. And they start their morning and they're actually in the off state, okay? They then take their levodopa medication, so their Cinemat, we call it, and it takes them a little time for that to kick in, but they're still off. And so that typical time is somewhere between 30 to 90 minutes for it to kick in. Once they cross this black line, they're now on. Their medication levels are increasing in their body, and they're on. Their symptoms are alleviated. But now as the dopamine levels reduce, their symptoms are starting to return. As soon as they cross this black line, now they're off again, right? And they may be off for a little bit of time before they take their next dose of medicine and before they wait for that medicine to kick in to the point that they cross the line and now, again, adequately controlled. But even during this time of adequately controlled, you can see the dopamine levels are changing related to how the medicine is being received in the body. Again, they go off and then they go on. And I would love to say it was as easy as this. This is as easy and reliable as motor functions go. However, it's often much more erratic than this, meaning sometimes this is shorter, or sometimes the peak is lower, or sometimes people even have what they call a failed dose, where their medicine doesn't even fully kick them into the on state. And so this kind of typical day, this is the easiest depiction of a motor fluctuation where it's at least reliable and you know how much sooner than your next dose of medicine you're going to start to wear off. That information is really important. And so back to your question of what should I do with this? Can I take my medicine early? There's a lot of other factors that need to be considered when addressing that question. And so it's really important to know, are you having hallucinations? Are you having dyskinesias? Is your blood pressure low with your medicine? What else is going on? Did you recently have COVID? And that's why you're having motor fluctuations. There's a lot of other things that can be contributing to a person's perception of their motor fluctuations. And that really requires your doctor's input. Sometimes I'll see people who are kind of like on the fritz of fluctuating, and they're not ready to increase medicine when they're in the office with me, but I sort of give them the liberty to say, all right, so between now and when you see me again, if you want to tighten your interval by a half an hour, go ahead. Or if you need to add another dose because you're wearing off too much, this is what I would do. So we kind of, it's like a chess game. You kind of anticipate the next move and give a person some leeway in terms of what you think they'll be okay with in terms of their medicine. I don't recommend just like me telling you to, it's okay to do it because I don't know enough and because I'm not your doctor. So I would circle back with them, but it sounds like it's a very valid question. Here's another important graph, and we're going to round up here quickly, but here's another important graph. So this is a person whose dopamine levels go up and down during the day. Below this dotted line, people are off. Above this dotted line, people are on, sometimes on with dyskinesias. And this person is taking L-dopa, carbidopa, levodopa at this time, and their dopamine levels rise. and fall, and then they take their medicine, their dopamine levels rise and fall, and so forth. But look, their curve stays within what we call good on time. No motor fluctuations are perceived, even though the person's dopamine levels are rising and falling. And so typically this is what may happen in the early stages of disease, where a person takes their Sinemet and they think like it's the miracle drug. Like, one dose made me feel better. Not everybody has this, but some people do. And that's because they're threading the needle really well. They're in this really perfect zone, where even though medication levels are changing, they don't experience a motor fluctuation. What happens is over time, when a person develops motor fluctuation, this curve, these ups and downs go outside the good on time. And so people do experience offs. They experience ons, offs, ons, like we saw in that earlier graph. And so that's when motor fluctuations happen. And it's not that you're just experiencing two curves. It's every time they cross a dotted line, they feel a transition. Here, 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 here. I don't know how many that was. It was a lot. And if you can imagine your body is in different states that many times in a day, that can be debilitating. And so this kind of a motor fluctuation can be treated, but typically this is a movement disorder domain, where, meaning like you need a movement disorder doctor, neurologist, to help with this kind of a situation. It can be very complicated. All right, I'm gonna skip advanced therapies for the sake of time. I'm happy to answer some questions if you have any. And I'm gonna leave my screen on resources of some vetted websites for individuals who have Parkinson's. I think I just forgot the Parkinson Voice Project. Anyway, anybody with questions?
I do have a question. Sorry, such a questioner. But I'm curious about, how do you encourage people to recognize that they are themselves and they are not their disease?
It's hard to do on like a blanket statement. I don't think I can say anything that's right to answer that question in just a couple words. I think prioritizing mental health is really important there. Having a person talk to whoever they feel comfortable talking to. Some people have a lot of positive response talking to a therapist or a social worker or somebody very familiar with Parkinson's, or even peers who have Parkinson's themselves. Some people don't benefit by doing something like this, by sitting here and hearing about all the things that may happen and then thinking everything's going to happen and then just feeling worse. I don't think there's a one fits all answer for any of these things. And I definitely have people who they're like, I will never show up at any of your talks. You can take care of me, but I never want to sit through any of this. And that's appropriate too. So I don't know how to answer your question. I think it's a very valid one, but I think it's like an individualistic one.
Thank you.
Mm-hmm.
Are there any more questions? I'm not hearing any more. Well, if there are no more questions, I'd really like to thank Dr. Solis-Cohen for coming today. Thank you so much. This was incredible. I think everybody got a lot out of this. And thank all of you for coming. I want to remind you that the next session, the medications and treatments with Dr. Trevor Hawkins, will be on March 12th. So make sure you attend that. That's probably going to answer a lot of the questions that didn't get touched on today. One last chance. Any questions before we close out? I guess not. Well, Dr. Solis-Cohen, thank you so much. Okay.
Thanks so much. Phyllis, I sent you an invite for next week.
Thank you. I saw
Yeah.
that. I'll respond to it when I get
Okay.
off of the Zoom. I'm looking forward to it.
All right.
Bye.
Bye-bye.
Thank you so much, Dr. Solis-Cohen. Thank you, everyone.
Let's see.